segment, which changes are possible?
Elevation
Or depression. Okay. What? Elevation of ST segment, depression of ST segment. What else? T wave. What is the normal size of T wave? That's number one. So if T wave is bigger, if T wave is symmetrical, it is named hyperacute T wave. So it is sign of ischemia. And one more type of ischemic changes is negative T wave. So there are four possible signs of ischemia. But also we can meet combinations of these signs. We can see elevation of ST segment plus big T wave. Elevation of ST segment plus biphasic T wave. Positive and negative phase. We can see depression of ST segment plus negative T.
That's
We can see depression plus big T. Any combinations are possible. The most typical combinations are this, and this. They are the most typical, and this one is possible too.
Can you say again the one before the last one?
This one, depression of ST plus negative T. So any one of these combinations are possible. All of them are signs of ischemia. Ischemia can be caused by two disorders. First disease is angina pectoris. Angina pectoris is caused by atherosclerosis. Because of atherosclerosis in physical exercises or emotional stress, patients' hearts do not receive enough oxygen. That's why patients start feel ischemia. But atherosclerosis provoked by physical, not atherosclerosis, ischemia provoked by physical exercises or emotional stress when heart start work more actively. After resting, ischemia disappear. So it is disease in which ischemia can disappear. Another case is myocardial infarction. In myocardial infarction, there is thrombosis of coronary arteries. It could be in area of atherosclerosis. It could be due to thromboembolism, if embol comes from another places. In this case, ischemia will not disappear without specific treatment, without specialized procedures. So, in both cases, ischemia looks similar. How to differentiate? Is it stenocardia, angina pectoris, or myocardial infarction? What do we need to do? In ECG, we will see similar signs.
Pain in the region.
In both cases, pain can be located behind of the sternum or in the heart region.
You take ECG before and after exercise.
So, patient have myocardial infarction. Patient's heart can be dead, and we give physical exercise to the patient to have a corpse, exactly.
The duration.
First, duration of pain. We need to ask how long patient feel pain. Pain lasts not more than 15 minutes. It's mostly stenocardia. Not always exactly, but if pain will disappear after 15 minutes, we can think that it is stenocardia. And ischemic changes in ECG will disappear after 15 minutes too. In myocardial infarction, these changes last more than 30 minutes. What else? First lesson, characteristics of pain in myocardial infarction and stenocardia.
In myocardial infarction, the simple are with the
Not in this
RV.
stage, not in stage of ischemia. We speak only about this stage.
In myocardial infarction, pain goes away after rest, I think.
After resting, ischemic changes will disappear if it is angina pectoris. If it is myocardial infarction, resting do not help the patient. And also nitroglycerin intake help to remove ischemia in stenocardia. In myocardial infarction, no. But all these criteria are not exact. To know exactly if the myocardial infarction or not, we need to prescribe laboratory tests. The fastest test is troponin, cardio-specific troponin. Could be troponin I or troponin T. Cardio-specific troponin is exact marker of injury of heart muscles, cardiomyocytes. In angina pectoris, troponin level is normal. In myocardial infarction, troponin level is elevated. So if we see patient with this picture, diagnosis which we need to write for our patient is acute coronary syndrome. It is first conclusion which we need to write. It is syndrome. Patient feels acute pain in the heart region. There is ischemia in the heart region. Next, we need to do differential diagnostic. Is it angina pectoris, unstable angina pectoris, or myocardial infarction? We need to prescribe troponin test. If troponin test is elevated, it is myocardial infarction. If troponin test is normal, it is angina pectoris. If it is myocardial infarction, what is the name of the stage?
Acute.
Not acute, not here. Stage of damage or ischemia stage, or in another words, it is named subacute, subacute stage. Subacute is begin after 1 month. It is supper.
Not sub.
This stage lasts from some minutes up to 1, maximum 3 hours. In average case, it lasts 1 hour. So, 1 hour later, if patient will not come to doctor, if doctor will not prescribe troponin test, if doctor will ignore patient complaints, we can see next stage of myocardial infarction, acute 1. In acute stage, there are exact markers of myocardial infarction. They are Q wave and ST segment elevation. If we see these two markers, patient has myocardial infarction in acute stage. I will. In this stage, also we can do differential diagnostic of size of myocardial infarction. Myocardial infarction can be one of 3 sizes. First size is small focal myocardial infarction. It could be subepicardial, subendocardial ischemia. It can look like a ischemic ECG, even if there is necrosis. Second stage is stage of necrosis. There is necrosis in the heart muscle. In most part of cases, it is look like a depression of ST segment. It is non-STEMI myocardial infarction. Second case, big area is with necrosis. In this case, we name this myocardial infarction big focal. Part of cardiomyocytes in this lead still healthy. That's why we can see negative Q wave, big deep negative Q wave, which show us area of necrosis. Next, we see R wave, which shows presence of healthy cardiomyocytes and elevation of ST segment. T can be big, hyperacute. T can be biphasic or negative. Last case, if there is affection of whole muscle of cardiomyocytes in D between AP and endocardium, it is transmural myocardial infarction. In this case, there are no healthy cardiomyocytes in this place. That's why our wave disappear. We will see QS wave plus elevation of ST segment. QS wave. Or we can see Q R small S wave elevation of ST. This is R small because of it is below the isoelectric line. So both cases are possible. Both cases are transmural myocardial infarction. So second stage, big focal myocardial infarction look like this. Transmural myocardial infarction looks like this, and small focal myocardial infarction looks like this. These two cases are STEMI. This case is non-STEMI. What does it mean, STEMI?
ST elevation,
ST
myocardial.
elevation, myocardial infarction. It is myocardial infarction with ST elevation. If we see ST elevation in stage of ischemia or in the acute stage, patient needs stenting. It is procedure when we introduce special, very small introducer to patient's coronary arteries under X-ray control. This introducer contains balloon. We add water or air to this balloon to enlarge coronary artery. This balloon dilation. Over this balloon we can put small net. This net will be opened with this balloon and will keep vessel open. This net is named stent. This procedure is indicated in any patient with STEMI. ST segment elevation, hyperacute T wave. This picture, these two pictures are indications to stenting. Small focal myocardial infarction don't need it. Stenting have to be performed as soon as possible. There is rule of gold hour. Patient have to receive stenting in first hour to fully recover patient's heart. If we will do it in first hour, patient's heart will not get necrosis. If we will do it later, necrosis will happen, but we can recover parts of the heart which are not necrotic yet. So we can save parts of patient's heart. We have about 6 hours to do this procedure. After 6 hours, it will not help. If stenting is contraindicated or impossible, we can do another procedure. We can do thrombolysis. We introduce special medicines which can solve thrombus in the heart, and it can help to restore patient's heart. But stenting is better. Outcomes of stentings are better than in thrombolysis. We can combine thrombolysis plus stenting. It is possible. Thrombolysis can be performed by ambulance. Ambulance look patients with ST segment elevation, for example. They can do rapid troponin test. If troponin test is positive, they have to start thrombolysis and go to hospital which can perform stenting. So it should work in this way. Not everywhere it's organized in this way, but it is more ideal way. Next,
Doctor,
Ah.
excuse please.
Yeah.
Standing as in the patient to stand or
no, stent,
Stent.
stent,
stand.
S-T-E-N-T, stent, stenting. Stent is name of net. Acute stage begins after 1 hour, so after beginning of the heart attack, and can last up to 3 weeks. In moderate, it is last 1 week. From 1 hour up to 3 weeks, we can see this signs in ECG. After 1, in some cases 3 weeks, we will see like ST segment start go down. ST segment is close to isoelectric line. T wave is inverted. T wave is negative. There is Q wave, there is negative T. ST segment is on isoelectric line. 3 markers of this stage. In this case, ST segment on isoelectric line, T wave is negative, there is QS wave. R wave will not appear. It will not appear in total. In this case, we will see only negative T wave. And stage number 4, which begins after 3 months and lasts whole patient's life, is named stage of reduction. Up to 4 months it is stage of reduction. After 4th month it is stage of post-infarction cardiosclerosis. Connective tissues that grow in affected area. Cardiomyocytes disappear and there is only connective tissue. It looks like a presence of Q wave in practically normal ECG. And in small focal non-STEMI myocardial infarction, everything looks normally. So Q wave, ST segment is normal, T wave is normal. If it is big focal, R wave is present. QS wave, ST segment is normal, T is normal. R wave will not appear. If patient had transmural myocardial infarction, patient lost his R wave. And last case is normal ECG. So, using these pictures, we can do conclusion about stage of myocardial infarction, size of myocardial infarction, is it big focal, transmural, or small focal? There is one more task in myocardial infarction, is detection of localization of injury. To detect localization of injury, we need to look at affected leads. We need to check which leads have ischemic changes.
She took.
Have I said you name of this stage?
No.
Subacute. It is superacute. This one is acute. Subacute reduction or post-infarction cardiosclerosis. So, last task. You need to examine every one lead and check leads which are affected. So, in this case, we've discussed about deep of affection. Now we need to check which walls of the heart are affected. So, lead number 3 is look at heart from the inferior wall. Lead number 1 is here. Lead number 2 is here, AVF, AVL. So, first AVL and 2 look at the anterior surface of heart and lateral one, mostly. A2, AVF and 3 together, all together, look at the inferior wall of the heart. Plus we have chest leads. V1, V2 locations are fourth intercostal spaces, right and left side. It is anterior side of the heart. V4 is located on the apex. It shows us apex. V3 between these leads, and it is in middle of the heart. It is septum of the heart. And V5, V6 are look at the heart from the side. It is lateral wall. So if we see changes in the first, second, AVL plus V1, V2, it is anterior wall of the heart. First, second, AVL, V3 is septum of the heart. Main lead is V3, another lead is assist to confirm it. First, second, AVL and V4 is apex. First, second, AVL and V5, V6 is lateral wall. Сейчас поведу. And the last one, second, third, and AVF, it is inferior or diaphragmal wall. These leads are the most typical and the most important. Also, we can see myocardial infarction in right ventricle, but it will look like opposite changes and it's difficult. You don't need it at this moment. Also, we can see myocardial infarction in the posterior wall. It will look like a very big R wave. In current moment, you don't need it. So anyway, if patient with heart problems, if there are ischemic changes in ECG, we need to prescribe troponin test to confirm is the myocardial infarction or not. Another walls are for cardiologists, not for beginners. Any questions at this moment?
Yes. Doctor, please can you I don't know if you can explain this part, sorry.
Which one?
Yeah, like everything you said
This?
there. Yeah.
This leads? First lead, look at the heart from the lateral side and anterior side. AVA, same. Second lead, in the middle of the heart. It can look at the inferior wall, it can look at the side or anterior wall. Third and AVF look on the heart from the inferior side. That's why these leads help us to confirm location of MI. If first, second, and AVA are affected, it could be lateral wall, anterior wall, apex, or septum of the heart. So we need chest leads to know exactly. V1, V2 is anterior wall, V3 is septum, V4 is apex, V5, V6 is lateral wall. If these leads are affected, these leads look at the heart from the inferior wall, from side of diaphragm. That's why it is inferior wall, diaphragmal wall of the heart. This picture is just to understand better why we use these leads.
Doctor, both that place you made scraps with chalk. The necrosis part, like here.
Small area with necrosis. In small necrosis, we will see this sign. In big necrosis, we will see this picture. This one. And it will go with these stages. If there is affection between epicardium and endocardium, whole heart muscle is affected, we will see this one, transmural. It is small focal, big focal, transmural. And stages will go like this. Big focal, transmural, small focal. Any more questions? Now I need to go, that's why we will do a break. We have to finish